continue the fight against gender-based violence affecting people everywhere. My name is Tarouk Faramand. I am the president and founder of WI-HER. We are a women-owned small business. We are based in the US and working globally. Currently, we are implementing a little bit more than 40 country programs here in the US and also in a variety of countries. And our main focus is on gender-based violence prevention and response, building capacity, of course, to address gender-based violence prevention and response, gender equity and social inclusion, human trafficking prevention and response, and also leadership and coaching. I invite you all to introduce yourselves in the chat. Please add your name, your email, the country you are connecting from, any thoughts or questions you might have, maybe since yesterday or the day before, or even today while we are presenting, and we will try our best to answer all your questions and respond to your thoughts. So it has been 33 years since the start of this campaign in 1991, and the numbers about people affected by gender-based violence and how it affects their lives are still very, very frightening. And today is the 12th day in this campaign. And as we move towards the December 10th date, which is the Human Rights Day, we must recognize that violence against women is the most persistent violation of human rights. I mean, 5 women or girls are killed every hour. Unfortunately, we will have 5 women or girls by the end of this webinar killed somewhere in the world. It's terrible. We at WI-HER are working diligently to prevent and respond to gender-based violence in a variety of sectors. We came up with an innovative methodology called IDEAR. It is based on the science of improvement, behavior change theory, and design thinking, and it is focused on building capacity to address gender-based violence in a variety of sectors. And while we understand the importance of sharing knowledge and thoughts about addressing GBV in those sectors, today we will focus on the health system, and we will pay attention to how important the strong health system can respond to gender-based violence. We bring to you an incredible group of professionals this morning and this afternoon that are working globally and locally to share their experiences and their ideas. The way the webinar will go today is that we have 2 parts to it. The first part, we will listen to our presenters. We will first listen to Dr. Avni Amin from the WHO. Each presenter will present themselves, and then we will listen to Dr. Amin talking to us about the global issues, and then we will listen to Dr. Kabiru from Nigeria telling us about services at the hospital level, then to Stella Abba telling us about services at the facility clinic level, and then to Ugo Nachi about services at the community level. That will be the first part of the webinar. The second part of the webinar, we will answer your questions, and we will also have a dialogue. Maybe you have a thought that you would like to present to us, to share with our presenters, and so on. We have received few questions from you all that we will respond to in the second half of the presentation or of the webinar. And just to kick it off, I'd like to share with you that while preparing for this webinar, we realized that there are high-level challenges that are consistent across all areas or all levels of service delivery that we will share with you today. The first one, basically, we're still facing stigma. Stigma is still a huge issue. We're still facing poor reporting. I mean, globally, as you all know, only 40% of survivors of gender-based violence report the issue. So this is still an issue that we would like to also address today. The issue related to coordination. I mean, I've been working on gender-based violence for 41 years now, and coordination has been an issue all along. So today we will also address the importance of coordination and how it is still a challenge. And then the importance of resources. This is another challenge, whether it's human resources or financial resources to address the issue in a variety of sectors. the gender-based violence is still a huge issue that we need to work on and to address. And I really appreciate that we are all united in this fight against gender-based violence. And on this, I'm going to invite my colleague, Dr. Amin from WHO, to share with us her thoughts. If you can please present, you tell us about who you are, what you work on, and move forward with the presentation.
Thank you, Tarup. So as Tarup said, my name is Avni Amin, and I'm the unit head for the Rights and Equality and Wellbeing throughout the Life Course unit, which is in the Department of Sexual and Reproductive Health and Research. And this is the unit where WHO's work on gender-based violence or violence against women, including in the humanitarian context, is located. WHO has been working on gender-based violence as a public health problem for about 20 years. And our work has primarily focused on generating the public health evidence for the magnitude, risk factors, and health consequences of violence on women, as well as given the mandate of the health sector, we have been developing guidelines for responding to health workers, for responding to violence against women that are for health workers. In 2013, and next slide, please. In 2013, we published the first clinical and policy guidelines for responding to intimate partner violence and sexual violence against women. And we picked these two forms of violence because they are the most common forms of violence experienced by women worldwide. These guidelines basically cover 6 areas for clinicians to address. The first is what we call woman-centered care, with recommending that health providers should at minimum provide what is called first-line support. And we'll talk about first-line support quite extensively as the main sort of care, that minimum amount of care that all health settings should be able to offer to any survivor who discloses violence. And we have a job aid called Lives to help operationalize first-line support, which is listen with empathy, inquire about needs, validate, enhance safety, and facilitate social support. Lives is really about empathetic listening and making sure that health providers provide non-judgmental communication, as well as respect women's privacy and confidentiality as a way to ensure their safety and offer referrals where they can. The other set of recommendations are to do with intimate partner violence, and we recommend clinical inquiry, not universal screening, but clinical inquiry, which is based on identifying signs and symptoms that are linked to violence. And on the basis of that, we recommend that all survivors should then be offered both first-line support as well as referrals and any other healthcare presenting health conditions that need to be managed. For the sexual violence survivors, apart from Lives, there is recommendations to offer comprehensive post-rape care services that include emergency contraception, STI treatment, HIV prophylaxis, and doing a complete history and recording and documenting the issue of sexual violence. We also recommend that health providers should be trained both at pre and in-service level, and that they should be trained not only in the clinical aspects of provision of post-rape care and intimate partner violence response, but also their attitudes, their values, their beliefs should be addressed, because we know that stigmatizing attitudes, as Tarup highlighted, can be a barrier for survivors to access healthcare. With respect to health policy, the recommendation is that care should be integrated into existing health services. So into primary healthcare services, into family planning, into antenatal care, maternal health services, into postpartum care, into child health and child immunization services, because we know that women don't often seek care specifically for violence, but they do come into contact with health services for other health conditions, be it for themselves or for their children. And that provides an opportunity for health providers to proactively then ask about violence in such settings. And the last set of recommendations are to do with reporting of intimate partner violence. And WHO does not recommend mandatory reporting to the police for adult women. And that is because we believe that women should make those choices and decisions and should be the ones driving the issue of whether they want to report to the police. And health providers should offer to report if that's what women want. But without their consent and without their knowing, reporting to the police, as is the policy in many countries, is in contradiction to the human rights principles of self-determination. Next slide, please. So we have, to help operationalize these guidelines, WHO has developed a number of job aids and practical operational tools to help implementation of these guidelines. And I'll point you to 3 of them. The first is a clinical handbook for healthcare providers. The second is a health manager's manual titled Strengthening Health Systems to Respond to Intimate Partner Violence and Sexual Violence. And this is for health managers to help them design, manage, monitor, and evaluate services. And then we have curriculum. And this curriculum is for training of health providers using participatory methods. And in order to help outreach the training even more, we have just launched an e-learning last week to help self-paced learning for health providers, because we know that many of them are quite busy and cannot be pulled out of their clinics very easily for face-to-face trainings. Next slide, please. So in terms of the country impact, we are supporting 23 countries that are implementing GBV Health Emergencies Initiative. And these are countries in crisis, either because of conflict or natural disasters or climate change induced disasters. And we know that from our reports that we've received from our country offices, about 73 countries, including Nigeria, report that they are using our guidelines. Next slide. So just to give you some examples of where countries have adapted our guidelines and have made use of them, in Sierra Leone, the Ministry of Health issued guidelines and training curriculum for health workers based on our curriculum. In Afghanistan, also a treatment protocol and our materials were translated into Dari and Pashto and used to train 7,000 health workers and improve health facilities in all of the provinces. And this was, of course, before the Taliban government. In Nigeria, the curriculum has been adapted by the FMOH and is waiting approval. And we are also implementing first-line support in northern Nigeria in the context of mobile health clinics. And in India, we initiated something called a Project Mukta, which was a hospital-based intervention in 3 hospitals, where we not only trained health workers, but had a health systems approach. And the curriculum basically was adopted as part of the gender curriculum for all 19 medical colleges in the state of Maharashtra, which covers 300 million population. And this project has now been replicated in another state in about 5 hospitals, reaching over 2,000 women in 1 year alone. Next slide. So just to give you a sense of why this Project Mukta in India was an important learning, was we not only focused on training, but we actually had system strengthening components, which included training of managers as champions, improving privacy and confidentiality in facilities, putting IEC materials everywhere in the clinic, strengthening referrals, giving a referral directory to the health providers, and establishing a documentation system in the health facility registers to record and document the number of cases. And we did this in 9 months. We trained 220 health workers, and we not only showed sustained improvements in knowledge, attitudes, and clinical skills of health providers, but these providers were able to identify 530 women and document them in the registers and support them with first-line support over a period of 9 months. One of the lessons we learned in this is that we were able to do this in partnership with a feminist NGO. And we showed that it's possible to have feminist NGOs work in collaboration with governments. And that is not only possible, but it actually can be a successful endeavor. and that we can actually change a patriarchal health system mindset. So the health workers, the health managers who often had beliefs that were very patriarchal and harmful to the healthcare, to the clients, we were able to address that through careful adaptation to the roles and responsibilities and considerations of what is feasible to do in a busy healthcare setting. These were hospitals that serve 50,000 clients a month. So they are extremely busy, but we were able to show that it is possible to do that in a very, very crowded hospital. So finally, just to summarize, what are the lessons learned, not just from India, but in a number of countries where we've implemented this, is that training has to be adult learning, so competency based and skills focused. And that's what our training materials, including the e-learning, strives to do. Peer-led trainings, so having doctors train doctors, nurses train nurses, social workers train social workers, has a lot of acceptability because the same cadre of health workers often can understand the roles and responsibilities and adapt the training to those particular roles and responsibilities. It's important to have joint training across the different cadres, so doctors, nurses, and social workers, for example, train together so that there can be a triaging and division of roles and responsibilities for supporting health women, and so that one person doesn't end up having to do everything. It's important that all health workers are trained in lives or first line support, but we may need dedicated counselors for additional psychological and psychosocial support because health workers are busy and they may not be able to deliver all forms of psychosocial support. You need senior management as champions, and mentoring and supervision we found was extremely important, including having refreshers and repeat trainings. We've learned now that one-off trainings are simply not enough. And you actually have to have repeat continuous education and training in order to have skills. And that training has to be flexible and in both modalities and timings, because it's impossible to get busy health workers otherwise. And it's important to not only think about the training, but infrastructure, to really think about how the clinic patient flow is directed for improved privacy and making sure that there are confidentiality SOPs in place, that there is a documentation system with facility registers, IEC materials and job aids to increase the visibility for health workers, and specifically that referral linkages with other sectors are strengthened, and it's an ongoing process of strengthening those linkages, and recognizing that health systems are a huge institution, often with their own ways of working for decades. And here we are trying to change not only the mindset of providers, but just the institutional way of working, and that takes time. Over.
Thank you so much, Dr. Amin. This has been very, very useful presentation, and thank you for being so committed to the time. We really appreciate it. This is an incredible wealth of information, and I just wanted to highlight that we appreciated the lives approach. We have adopted and adapted it to and made it consistent with our IDEAR methodology. And we implemented this training in where we joined the two approaches, the lives and IDEAR, in Kenya, which yielded incredible results that we published, and we will be happy to share with you the publication if anybody is interested. It's also on our website. So thank you so much, Dr. Amin. Now we're going to move to one country and one country only for today's session, because we wanted to focus on the different service delivery at different levels of service delivery in one country to demonstrate the variety of services provided. So we focused on Nigeria. We invite Dr. Kabiru Atta, the country representative of EngenderHealth, working on USAID Momentum, to share with us your work at the hospital level. Please go ahead, Dr. Kabiru.
Thank you very much, Taro. Good morning, good afternoon, everyone. I'm pleased to be here. Yes, so my name is Dr. Kabiru, the country rep for EngenderHealth, currently implementing a USAID-funded Momentum Safe Surgery project in Nigeria. So really the project is focused on prevention and management of fistula and female genital mutilation. One of the things we recognized early on the project was how gender-based violence is both a cause and a consequence of FGM and fistula. And hence there was a need to engage in this GBV programming. I think what hit us first as we entered this space was really around the poor coordination of actors, especially in Ebonyi State, where one of the states we work. And so one of the things we did was to have strong advocacy to several partners, including USAID partners, the EU Spotlight Initiative, and several other actors working in this space on the need for us to come together to support the one-stop center in Ebonyi State. So in Ebonyi State, we work in the National Obstetric Fistula Center, who has set up a one-stop center that is supposed to provide services, psychosocial counseling, and referrals, clinical management of gender-based violence to fistula clients and all other GBV survivors within the community. So at the facility level, we used a system approach. When Dr. Amino was speaking, she talked about system strengthening. So we used this health system approach to say within this health facility, let's apply the building blocks. And so at the leadership level, we realized that there was a need to form a multi-sectorial committee at the facility, which involved not just the clinical management staff, but needs to bring in a representative of the legal team, representative of the police, and other counselors, so that it's multi-stakeholder, and then everybody feels represented and they have a voice on the table. Of course, the center being located at the Norfolk Center, we had to also speak to the management, which is the medical director, so that he sees the value and is able to invest in the center. We also analyzed the human resource for health, where we identified that they only had one counselor at the center who was supposed to provide services to everyone. Of course, we knew it was insufficient. And so following a series of advocacy, the hospital was able to employ additional 5 counselors to support the center, which was really good. Of course, with this employment, we worked with other USAID projects to support the training, mentoring, and capacity building, really just building capacity of these counselors and other clinical staff to be able to provide comprehensive GBV services. And then we moved to the service delivery components, and we realized there were structural issues. The first is there was really no standard screening tool for them to use. They also the distance from the ward to the one-stop center was quite far, and so which meant that there was a need to move one of the counselors to go to the wards to be able to provide counseling and then apply the GBV screening tool following consent. The USAID MCGL project developed the screening tool, and then we worked with the counselors as well as clinical staff to apply the screening tool to the fistula clients within the wards. This helped us to be able to. We started as at April 2023. No client had been screened. No fistula client had been screened for GBV. By between April to June, we had 49 fistula clients, and only 7 consented to screening. And so we realized that this number was low, and so we had to intensify the counseling within the wards. And then by last quarter, we had 66 fistula clients. 51 of them agreed to be screened, and we identified 13 cases, clients who had actually experienced GBV, structured around physical, emotional, sexual, and FGM, which was really helpful for us. And these clients were now then supported by the one-stop center. It's important to mention here the use of data for decision making, and this meant we had to engage to ensure that this one-stop center had the GBV case management tools, the post-GBV screening tools, and several other tools to be able to document this service. And then the M&E team supported them to be able to validate this data and use it to improve services or to advocate to the medical director for more support. I think one important use of this data was it showed that the center, despite the fact we were now identifying fistula clients who had experienced gender-based violence, the center did not have enough clinical equipment to actually do case management. And this led to an assessment was done, and currently our project, along with other projects and the center, are now working to see how they can invest by next year to procure several of these equipments to improve services within the facility. So this is just a brief about some of the work we are doing at the secondary and tertiary level in Nigeria. Thank you very much.
Thank you so much, Dr. Kabiru, for sharing your thoughts with us. We really appreciate your presentation and sharing thoughts about the 6 building blocks and how you improved screening and services at the facility level, at the hospital level. We really appreciate how you brought in the different service provider and including the police. We received a question in that regard, and we will highlight at the end of the presentation. We will invite one of the panelists to also shed more light on it, and how we at the facility and also at the community level need to involve other providers to, in addition to health providers, to improve services. So thank you, Dr. Kabiru. Now we're going to move to sharing thoughts about services at the facility clinic level. I am delighted to introduce Stella Abba, my colleague from Nigeria. WI-HER is implementing 6 programs in Nigeria, in 6 states, in fact. One, which Stella will talk about, is the Integrated Health Program. This is funded by USAID and led by Palladium. And we have also a program on neglected tropical diseases. So Stella, go ahead. And if you can lower your screen so we can see your face. We can see your face. Yes. Yeah, we saw the air condition. We prefer to see your face. Thank you, Stella. Go ahead.
Thank you, Dr. Taru. Good morning, good afternoon, good evening. My name is Stella Abba. I work as the Gender Equity and Social Inclusion Advisor with WI-HER, working on the USAID Integrated Health Program here in Nigeria. The USAID Integrated Health Program is a 5-year funded project, and the goal is to reduce maternal and child mortality and increase health outcome at the primary healthcare service level. The key beneficiaries are also women, and WI-HER is also working on this project as a consortium partner to lead JC integration across integrated health service delivery. Next slide, please. Next slide. Okay, so in a bid to prevent and respond to gender-based violence in the primary healthcare system, we had some of the program interventions that we implemented, looking at the startup of the project, which we understand that there were gender desk review, which reviewed that the system capacity of the primary healthcare center staff was very much low in terms of responding to gender-based violence in the health system. And so 1,890 healthcare workers were trained in over 700 primary healthcare centers using the WHO adapted clinical guidelines on lives, and in partnership with the State Ministry of Health and the Federal Ministry of Health. This was also followed by on-site mentoring of the facility staff, which is also an important aspect if we must maintain or sustain implementation in service delivery. We also partnered with the Federal Ministry of Women Affairs and States to also develop a referral pathway, which guides the aspect of referral to different sectors in the health, in the legal sector, in the security sector, and the social welfare, and also to ensure that we facilitate referral that is effective and warm. We also supported the state in the establishment of the Sexual Assault Referral Center in the management of GBV cases that are referred to the center. And in the referral centers, the SAP centers, we ensure that services were provided free of charge for the survivors of gender-based violence, including transportation fares to facilitate referral to different sectors such as protection, For those who want to pursue justice at the legal services, they were also linked for services in those sectors, and also they were supported to reach those services by facilitating and getting them with transport logistics to help them get to those areas. The GBV indicator is also now included in the National District Health Information System, which is also now captured as a health determinant and also being reported and used for proper decision making. Next slide, please. So building on this program intervention effort, where there has been consistent improvement and increase in reporting trend on GBV data as seen displayed. Capacity of the PHC staff that was developed on GBV identification, documentation, and referral also contributed to the steady improvement seen displayed in the chart. There is also an aspect of availability of GBV documentation tools, such as the screening forms, the assessment form, the service delivery forms. All of these are contributed, and also GBV data is also being disaggregated by sex, by type of cases, and to also ensure quality documentation. We also incorporated the aspect of monthly data validation of GBV data, leveraging on the LGHA and state structures. This also helped to improve quality of data which is being reported, and also the ownership, because the government owns this process, and every data that is reported on a monthly basis is validated by the government and also entered into the DHIS directly at the LGA level. We commenced implementation in FY22 Q4 with less than 1,000 GBV cases reported, and over time, we are already in FY23, and we have increase of over 7,000 GBV cases being reported. Next slide. On this slide, we also looked at the aspect of GBV data being properly disaggregated by type of cases, and physical, sexual, denial of resources, and physical assault and denial of resources were the most common types of GBV cases that has been recorded, with also women above 20 years being contributing to the high number of cases that were documented and reported. Next slide. Next slide, please. How do we foster health sector collaboration with other community-based organizations? We build on the existing structures, such as women groups. This can help to increase awareness on GBV and facilitate referral support. And the time past, we've worked with women who are in savings group. They've been able to support other women to access even emergency obstetrics referrals and other health interventions. And having these women learn information on GBV and use it to also sensitize other women, will help them to facilitate discussions on GBV issues amongst their own safe space. And this can also help them to support other women who are in need or who also face different forms of gender-based violence to access care when required. Next slide. Some of the institutional reforms that we did is that we created, following the training that we did of over 1,800 healthcare workers, to ensure accountability for GBV care, we've been able to institutionalize at least one GBV focal point in that facility. We also engaged with the community leaders, the ward development committees, and financial management, facility management committees to help facilitate community GBV referral linkages. This has also helped us to operationalize utilize the GBV referral directory. They know who to call, where to also refer different GBV survivors. We also established a functional GBV technical working group, and this has helped to improve coordinations with the Ministry of Women Affairs and even with the State Governor's Wife's Office chairing its affairs. It has also helped to strengthen the functionality of the technical working group, who are always on site to ensure that all survivors are supported when needed. There is also high level advocacy and engagement with key influencers, which helped us to also secure GBV budget line in the Ministry of Women Affairs and in the health sector, which has not been before. Usually things around gender-based violence has been neglected, and some of this funding for SAC also facilitated the designated court to help expedite speedy prosecution of perpetrators. And currently in one of our implementing states in Kebbi, we have for the first time a life sentence of a GBV perpetrator. And also under the multi-sectoral referral, one of the things that having a designated GBV budget line has helped us to secure is in terms of the referral, working with the security sector, which in time past, mostly families of the survivors were asked or were tasked to bring money to feed perpetrators who were arrested by the security personnel. But with the budget line in place, every sector now have resources to support their own services and response. And also in terms of capacity building for healthcare workers, this has also helped to improve health workers' attitude and knowledge around their personal bias, around GBV survivors in terms of stigmatizing them, discrimination. And also sometimes when they see cases at the facility level, they usually feel that this is not within the jurisdiction of the health sector, and usually they will refer it either to the community and tell them to go and deal with it there. But with the training and capacity building, they've been able to understand that the health sector has a lot to offer in terms of building, counseling the survivors, treatment and also referring them for further services that they will require. So overall, we'll say that the importance of these institutional reforms for WI-HER is targeted towards sustainability, and all these reforms can also be sustained because every work that is done is targeted at working with the state and making sure that the state also lead the process to ensure that after project closeout, these activities are also sustained. Next slide.
Yes, Stella, we need you to move forward, really.
Okay, sorry. So some of the...
Okay. Continue.
Okay. I can't see my slide, but then...
Okay, you can talk about it, or Fatima, can you show the slide? Yes, please go ahead, Stella. Quickly, if you don't mind, we need to give time for questions and answers. Go ahead.
Okay, so these were just the few pictures that showed some of the activities that were carried out in the field. Here we are having on-site mentoring following the capacity building of the healthcare workers. We also took the SAC personnel, the medical doctors, the counselors, and the nurses on a learning visit to another SAC where their capacity was built on GBV clinical care and forensic medical examinations. Thank you. And over.
Thank you so much. Incredible work. We really appreciate your thoughts, and I want to emphasize the importance of institutionalizing those activities where the state is taking the lead and the national players are taking the lead. This is very important. The project is closing soon, so we are very proud that we were able to secure complete ownership at the local level to continue with this program without the project itself. So thank you so much, Stella. We appreciate it. Now we invite our colleague, Uno Nachi, also from Nigeria. She's going to talk to us about working on gender-based violence at the community level to address it and reduce it. Go ahead, Dr. Ugo.
Thank you very much, Taru, and the other speakers. My name is Ugo Nachi. I'm the Executive Director of Daughters of Virtue and Empowerment Initiative, Dovenet. And Dovenet is a women-led, women's safety and empowerment organization. It's a nonprofit based in Ebonyi State, Nigeria. And Dovenet is implementing the Momentum Country Global Leadership Project on community level interventions. We are also implementing the Momentum Safe Surgery and Maternal Health Project also in Ebonyi State. This project actually has a lot of link with gender-based violence, intimate partner violence, and other issues that are related to violence and the protection of the rights of women in the communities. Next slide, please. Okay, in our work in the communities, we have had to come in contact, with the people, with the survivors, with community leaders, with community members. And in the course of our work, we met a lot of challenges. One of those is the reluctance of the survivors in coming up, because of the culture of silence. We actually are in a patriarchal society, a society where women's voices are in whispers. And so many of them are not willing and ready to report issues of violence. And so that's what we met. And so the level of reporting of issues related to violence was very, very low. And what we did was to now get involved work with the community, work with the health facilities to create safe space and confidential spaces within the healthcare facilities and then in community centers. And that also helped to now get the people to open up, and be able to come up to report any form of violation or any form of violence that they experience. It also provided the opportunity to have a one-on-one counseling between the health worker and the survivor. And they are able to open up and explain exactly what is happened to them. And then we also have a community-wide campaign to create awareness on GBV, because the level of awareness was very low. But because of the campaigns that we carried out in the communities, we were able to go to have market campaigns, community dialogues, and the people are able to have ideas of what we are talking about, the dangers of GBV and the impact that it has in their lives, especially when we talk about female genital mutilation, which we witness in some of the communities. And then we also have the link between female genital mutilation and fistula. So by the time we share some of this information to them, they are able to now come out and then begin to drop some of those traditions or cultures that actually impinge on the health of women. On the issue of female genital mutilation, it's something that is, Ebonyi State happens to be one of the states where we have a high number of involvement in female genital mutilation. So then, next slide, please. Thank you. So in the community, we have to get the community to have a buy-in to address some of those issues, ensure that there's cultural sensitivity. Because if you get into the community and you're not, you begin to bring in something that is alien to the community, definitely are not going to listen to you. So we have to train staff the way to relate with the community, the way to talk to them, to know their culture, to know some of the things that they may not like to hear, and they are able to have a buy-in. I can recall in one of the sessions where we invited women from the various communities, and they all gathered and we're talking about female genital mutilation, trying to show them pictures and what it could happen to them. Many of them started gradually walking out from the meeting because for them, they have all grown in the culture of silence. They do not want to talk about anything that affects their organs or anything like that. But gradually we began to now engage with the local influencers in the community. We began to engage with the community leaders who now started explaining to the people that a lot of changes are coming in, and whatever actions we are taking is in the best interest of their health and the health of their children and the health of the community. So in Ebonyi State, a lot of, is a multi-sectoral approach to address the issue of FGM, which is a key concern, for each and every one of us. So some of the traditional rulers in many communities were brought in to now sign an abandonment, sign a common document, a common message, abandoning FGM. And it is quite effective. And that's what has helped to reduce the level of resistance within the community. So all community members in the entire state, everybody is now aware that FGM is banned because there's a law, the VAP law in the state also has sections banning FGM or any form of violation of women that will affect their health. We also prepared some culturally tailored communication materials that will be acceptable. If you get into a place and you bring up materials that may not go down well with them, they will reject it and they will not be. But now you place materials that are culturally tailored, they are interested, they stand on the materials, they look at it, they even struggle for some of those materials to paste in their homes, sharing the message. And that is quite helpful. And that's how we have broken the resistance within the community. Next slide. Okay, these are just some of the pictures, some of the activities to address reluctance. That's the secretary to the state government. The last slide, please, before this. Yes. So this picture is the secretary to the state government. They had to help. We had to partner because I remember one of the speakers had talked about the need to collaborate with government. And we also have found that opportunity through the MCGL project. And this is a safe space that was created by the MCGL, which the government is also very happy about. And that's why they came for the inauguration of the safe space. And so women who are violated are able to come in and, share everything that will help them. The next thing is you can see we're fostering multi-sectoral collaboration. That's what these are pictures taken in the communities. You can see the traditional ruler, the police, and all those other people. Then in the health facility, we also work to strengthen the health workers to be able to get the necessary data that we require, so that anytime anybody asks how many people have reported about GBV, because there's been a low reporting before now. But with the collaboration that we have with the health workers in the health facilities, all that has changed. The reporting has increased, and the people violated, the survivors are able to share information. You can also see in this last picture, in the picture, the violation, the linkage between the community members and the health workers.
Thank you
And the last picture are just that of the women. The last picture is the women where we went for sensitization, shared with them about what the GBV is all about, and they are happy to display what they have heard. Thank you very much.
Thank you, Ugo, so much. You generated a lot of questions, and we probably need to organize another webinar to address FGM because it's an important issue. But if I can start the Q&A, we have 10 minutes. I'm gonna start with you, August, since you just covered FGM and we have 3 questions. And if you can just very briefly, please, describe to us to what extent is the law on FGM welcome by women who are candidates for or subject of this practice. And then have you tried understanding what value or benefits the women attach to female circumcision? If you can answer those 2 questions, please, and then if we have time, and I can ask the 3rd one. If not, we can respond in writing. But before I ask you to answer those questions, Ugo, I just want to mention that we worked a lot on FGM in Egypt, and USAID and other donors have been sponsoring millions of dollars of projects addressing FGM. It is still a very big issue because it's culturally ingrained. But Ugo, please let me know what's the situation in Nigeria. How welcome is the law by women? And then what is the benefit that women see in FGM in Nigeria?
Thank you very much. I must say the law has been very helpful. The law has been helpful. We just need a lot more push in terms of implementation. The law is welcomed, and not just the law, the fact that they now realize the health implications of FGM. Many people are now abandoning FGM. I remember I went to one of the communities on a community sensitization, and one of the men got up and informed us that he had planned to send the daughter for circumcision in the December of that year. But for the fact that we have come for this sensitization and explained everything to him, that he's not going to do that, and he became one of the advocates, moving around the community to ensure that people do not continue with the cultural practice. As you have said, it's a cultural practice, and many people use it as, maybe a sign of puberty, trying to, maybe get some things from it on behalf of their daughters or their wives. But the sensitization is something that is changing that. And then the law, because in most communities, GBV task force has been put in place. And the GBV task force is put in place with all the relevant agencies, police, the judiciary, the justice system. So everybody is there. And so with the GBV task force operating at the state level and operating at the local government level, that is very helpful. And some of those, the moment they know that if anything that happens, they will be prosecuted, many of them are now drawing back. And we're also working to ensure that some of those circumcisers who do not have any other economic title and anything economic to support them, we are now trying to, direct them to other things that they can do to earn. So there's a huge understanding about the implications of FGM as far as we are concerned. But, we still have a lot more still needs to be done in terms of publicity, in terms of showing, getting into remote areas, because sometimes we do not have access to get into those remote areas as a result of funding or, as a result of, getting support to really reach into those interior places. A few weeks ago, I was called to inform me that one of the interior places that they still do, they carry out FGM. I was so pained, and I'm still working on how to start, get into the place, hopefully by the beginning of January next year, to ensure that we speak to them about it and we change their attitude. We also work in collaboration with the health facilities to continue to ensure that this does not happen anymore.
Thank you so much. Thank you, Ugo. I mean, this is a big issue, and in Egypt, for example, even if the law prevents FGM, it prevented it for many years. It has been in place, the law against FGM. First, it was basically against anybody who will do it and allowed to do it in a medical setting. Then the medical settings were prevented from doing it, but still people are doing it under the table, if you will, or in a way that will not reveal, unfortunately. Lots of cultural issues associated with FGM. But there is a lot of work needs to be done at the service providers level to basically stop this practice, and also at the community level to change behaviors, not only behaviors of men, but also of women, because mothers encourage, and grandmothers and mothers-in-law encourage this practice still. So it's not only about men. We need to make sure that the whole community is basically on top of it. Thank you so much, Ugo. There's a question about the healthcare staff attitudes towards GBV. This is very important. I'd like to maybe ask Dr. Amin to talk about it. Have you seen at the WHO level any change in the health providers' attitude towards GBV and how they deal with survivors? Because we've noticed a lot of negative attitudes towards survivors in the programs that we're implementing. I'd like to hear from you, Dr. Amin, and then if any of the panelists would like to add some thoughts, please go ahead, please.
Yeah, just to say, we have a questionnaire which measures knowledge, attitudes, and practice of healthcare providers. And we have a number of questions in the questionnaire around healthcare workers' own attitudes and beliefs towards gender-based violence. So what we have done is in India, for example, we did it as part of a formal study, is we measured the attitudes at baseline, so before the training, immediately after training, and we followed them up after 6 months. And you can do that 6 months, 12 months, however you decide, to see what the changes were in knowledge, attitudes, as well as clinical practices. And specifically, we asked how healthcare providers were identifying survivors and whether they were offering lives and which aspects of lives. In addition to that, and we saw that not only did attitudes change from baseline to post-training, but that change is sustained over 6 months. The second way that we often look at the changes in attitudes of healthcare workers is really if the reports of GBV increase. And it might sound contradictory or counterintuitive, but really, the reason women don't report GBV to health workers is because they don't trust them. They're afraid that health workers will be judgmental, will stigmatize them. And if your health workers are well trained and you've addressed, all of the gendered attitudes that they hold, and they're able to translate that into clinical practice, then what you should expect to see is more and more women over time coming and reporting GBV to health workers. So in many ways, what you say is the proof is in the pudding, is actually women are not stupid. If they don't believe or trust the healthcare worker is going to treat them well, they are not going to report GBV. So if more and more women are coming forward and more and more women disclose, it's actually a good sign that your training has been effective in changing the way health workers are treating women. What we found when we did the interviews and the study in India is we actually interviewed the women survivors who had accessed the services, and we asked them, so tell us what your experience was like from receiving this care. And what they told us is really about the way they were spoken to, the way they were treated with kindness and respect, and that's what women want from health care workers, is that survivors really want the health workers to respect them, to take their problems seriously, to ask them about it, to give them the help. And that's what women told us, is that they felt good because they were treated well. And that is basically another way to measure whether you've done the training in a way that has impacted changes. And I saw that in one of the presentations the number of women who were reporting went up from 1,000 to over 7,000, and that is a sure way of knowing that the training is working because women are coming forward.
Sure. Thank you so much, Dr. Amin. I'd like to add a few thoughts here. I mean, training is extremely important and critical. What we do at WI-HER, we focus heavily on sensitizing providers as well, because many of us providers have been either subjected to violence themselves, and even during our trainings, we deal with re-traumatization. So it's critical and important that we add a very focused sensitization session to providers, because they themselves come in to provide the service with biases or with trauma themselves, or there are many issues they themselves as people have been affected by. So sensitizing health providers is critical and important. In Kenya, we did this during the beginning of COVID, and while it was very challenging to do it online, we were successful in increasing screening and providing services based on WHO guidelines to women and men who are seeking services. Unfortunately, we can only report on disaggregate by sex, we cannot, or age, we cannot disaggregate by other factors, because that's the way the data works in different countries. But we were able to increase the numbers of people served by 600% among women, among men, and by a large number, now I cannot recall it, but I always remember the number of men, because we need to also pay attention to men survivors, right? Not only women. We know that women are more subjected to violence, but also men are subjected, and we need to pay attention to that. I'd like to move forward with a question that we received yesterday regarding the police. Stella, if you can just, you talked about the police, but if you can shed additional light on how you worked on the relationship between police and health services, just very quickly, because we don't have much time and we have so many questions, and we really appreciate your questions. Go ahead, Stella.
Thank you, Dr. Taru. It is important to clarify that in responding to GBV, it requires a multi-sectoral approach, and both the health sector and security sector work collaboratively to respond to gender-based violence. And in Nigeria here, we have different security firms that we work with. We have the police, we have the civil defense, NAPTIP, and other community surveillance structures available. So in this sector, the security sector, we've been able to institutionalize our gender focal point in those sectors, and being our focal points, both in the health sector and in the security sector, all GBV cases pass through them. For instance, we had a case of a pregnant woman who was being physically abused by her mate, co-wife. And she was, after the abuse, she was referred to the facility, and our gender focal point picked it up and also counseled her on the need for her to get a restraining order if she really wants to have a healthy pregnancy outcome. And so the gender focal point of the security sector was alerted, and the woman was arrested. You know, when you look at our Nigerian context, first thing that will come to mind is that, oh, the family members might not really like the fact that I want to report this case and taking my co-wife to the police. But we made her to understand that she really needs to stay alive before she can also think about other family members, that it is not about separating them, but getting a restraining order will help to ensure that she stay healthy and give birth to also a healthy baby. And together, both the health sector and the security sector was able to work together, get the woman arrested, and also got a restraining order. And she was able to write an undertaking that she's no longer going to abuse her. And I can tell you, the woman was able to give birth safely And till today, we've not had any form of complaint from her own angle. So using the referral pathway, survivors are linked to the security for protection, some of them for investigations, and those who also want to pursue justice are also referred to the justice system. And also our agenda focal point also follow up to ensure that these cases are not truncated, and also the family members are not allowed to go through unnecessary pressure while trying to pursue justice. Thank you.
Thank you so much, Stella. Do we have other thoughts from other panelists, or can we move on? Any other thoughts? Ugo, Avni? Go ahead.
I just posted some resources in the chat. There's a question about prevention of FGM, and
Yes.
I've just flagged the fact that WHO has just completed a 3-country randomized controlled trial looking at the role that midwives can play in preventing FGM using person-centered communication approach. And the results have been extremely promising because they showed not only that midwives, their own attitudes towards FGM changed, but the clients that they served, and this was during antenatal care, they themselves indicated very clearly that they were not intending to perform FGM on their daughters. And so we are using the results to scale this up, I think, in Kenya and Guinea in the coming years. So hopefully we be able to see how health workers themselves, given the important role they play as opinion leaders in their communities, as well as role models, can play in prevention of FGM through this approach.
Thank you so much, Dr. Amin. Kabiru, can you please, Dr. Kabiru, talk to us a little bit about data? We received a question about the importance of data. I mean, we addressed data, a lot, but if you can just very briefly highlight your thoughts about data, we would appreciate that.
Yes, thank you, Dr. Tarub. Of course, I'll speak for Nigeria. Currently, on the National Health Management Information System, we have 3 GBV indicators, which really are looking to capture number of GBV cases seen, number of GBV clients who receive post-GBV care, as well as number of GBV cases who are referred for further treatment. There was a discussion about 3 weeks ago to look at possibly adding more indicators, especially around on tools used by the secondary healthcare facilities in the country. But I want to speak really about how, because there's been an increase in the data management system and improvement in the data management system, we're beginning to see that data. And how, I think for me, what's important is how are we using this data to improve services or to improve our programming? That for me is the key thing. I don't believe we necessarily need so many indicators, but the ones we have, how are we using it to capture, to improve? I'll give you an example. We're just looking at the data from the Fistula Center in Ebonyi State. We for the GBV screening tool, we identified that about 14% of fistula clients, only 14% consented to have that to be screened by the tool. And so we went back to say, why only 14%? And we discussed with a few women, and we identified issues around stigma and discrimination. And most importantly, the mistrust in the system to be able to provide services if they're identified to have GBV cases. And so we had to go back, do a lot more counseling, engage the women more to assure them that the services are available to support them. And in the next quarter, we had 90% of fistula clients actually agreeing to be screened by the tool. So it means more women was more confident in the system. But it's good to sound a warning here that we need to match the demand, because with all the work we're doing at the community level, all the sensitization we're doing, we're raising the hopes of women, of men who have experienced this gender-based violence. So we need to make sure that there's also concurrent investment in the supply side, because if we have more women reporting, but the system is not able to respond to them, there will be a backlash, and of course there will be further distrust in the system. And I think that's why the health systems approach we're using, especially working at the facility level, is really helpful, because then we're able to respond as we see the numbers increasing. We're going to say, okay, do we have enough human resource for health to be able to manage this increased number? Do we have enough facilities and enough equipment to take on these new cases? So just to highlight that part and add that to the conversation. Thank you.
Thank you, Dr. Kabiru, so much. We really appreciate it. I have few thoughts and a quick question to Dr. Amin, and just few thoughts before I ask the question. As we all know, gender-based violence is not only recognized and addressed in the health sector. It's, of course, we focus today on the health sector, but we have been working at WI-HER to address gender-based violence in a variety of sectors, whether it's energy, whether it's agriculture, construction, you know, you name it. We have been working also on conservation projects. Now we're working with plan on an activity in Kenya to examine gender-based violence in biodiversity programs. So it is so critical that we keep ourselves aware and keep looking for ways to address GBV. Now with climate change, with the increasing violence in different countries, Dr. Amin, I wonder whether WHO is doing anything to address gender-based violence against women in Gaza. Because of the war, we have been hearing reports from UNFPA that 50,000 women who are pregnant or delivering have been subjected to violence. Some of them were killed, some of them did not receive services. So any thoughts you can tell us before we end the meeting, please?
Sure. Just to say, even before the current conflict in Gaza, we have been working for the past 5 years through a special initiative called Gender-Based Violence in Health Emergencies, or in emergencies rather. And we started with 5 countries, supporting 5 countries facing different types of health emergencies, be it conflict or disasters, either due to climate change or others. And now we have expanded our support to 23 countries experiencing different types of crisis. OPT or Palestine was one of the countries that we were already supporting before the crisis, before the current crisis. And a lot of our efforts went in training health workers, including mental health specialists, to identify and respond to the trauma brought on by GBV, but also to provide post-rape care services. At the moment, as you can imagine, it's extremely challenging for our colleagues on the ground to be present and to be supporting and to even frankly be able to move securely. So I can't tell you at the moment exactly what kind of services are being provided, but we have made sure that all of our materials are adapted for humanitarian settings. We have a number of e-learnings and working with the health cluster, which is in all of these crises, including in OPT. So they are aware and they know. But I can't really tell you, whether this is right now being happening in the middle of an active conflict, given all the challenges.
Thank you so much, Dr. Amin. I mean, it's critical as professionals to continue the discussion and find ways to operationalize those guidelines in a setting like in Gaza, because health workers cannot reach, people cannot reach health workers, hospitals have been attacked, and women have been having C-sections without anesthesia.
Yeah.
So it's critical that we keep looking for ways to operationalize those guidelines so we can provide those better services. We really
just to say that I think I mean in conflict situations, we don't just work with the government health sector, but there are a number of NGOs that are providing services on the ground, and we do work with them. There are emergency medical teams, and we're trying to train them. And on the Egypt side, which is receiving many of the refugees through the Rafah border. We also have been working with the Egyptian Ministry of Health, who's also been doing some extensive training. So,
Thank you.
yeah.
Excellent. Thank you so much, Dr. Amin. I know it's a very challenging topic, but thank you for your thoughts. I would like to just close by thanking everyone and really, really appreciate the discussion. We have received a lot of information. Thank you for the panelists, for my team who organized a wonderful event. And I invite you all to learn more about IDEAR, which will help you change behaviors among men, women, and community members to address gender-based violence. So if anybody is interested, email us. And we would like to ask you for your thoughts. Fatima, if you can show the QR code. If you have time and you can just give us your feedback, we would really appreciate it. We're going to keep it open for the next minute. If you can just, it's just 2 questions. And we really appreciate it and have a great rest of your day. Thank you so much.